Today, we are super happy to welcome Dr. Wendy Sacks, who's going to be talking to us about thyroid health. She is from Cedars-Sinai, and she will do a more thorough introduction of herself for you.
I'm actually in Los Angeles at Cedars-Sinai Medical Center, which is kind of a mixture of a community hospital and also has its own teaching programs and a new university attached to it. So we have a lot of students here, a lot of residents, fellows, and back when I was studying as an endocrinologist, which is the study of the glands, I was trying to decide what I wanted to do. And one of my mentors said, "Oh, why don't you come and do an extra year of thyroid with me?" And I said, okay. It was serendipitous. And now it's been over 20 years and I've really delved into the thyroid. Here at Cedars, I see patients in the clinic and I do teach our fellows and residents and I supervise them when they see patients both in the outpatient clinic and on the wards. It's really fun. And this is going to be very relaxed, a very general overview. My title was thyroid disease, but I like how Frances said thyroid health. I'm going to present to you a general overview and then what the potential things that can go wrong with the thyroid. As I mentioned before, I'm an endocrinologist. Endocrinologists study the endocrine system, which is made up of the glands in our body. And there's many of them. As you can see here by this illustration, starting from the top and going down, we have glands in our brain. The hypothalamus is the master, and the pituitary are both called like the master glands. They really control a lot of how our glands work in the body. So that's in the brain. The thyroid gland is in the neck. It looks like a butterfly. It's got two parts to it, or three parts really. The right lobe, because we're looking at the picture, this is the right side of the body here. So right lobe, left lobe, and then the connecting part, like a butterfly, is the isthmus. Then there's the thymus, which usually we're born with, but then over time it shrinks up. It helps with immune function. So many of us don't really have a thymus anymore. And then the pancreas is in the abdomen or in the gut area. And this is a gland that has islet cells that make insulin. Insulin is a hormone. That's why endocrinologists take care of people with diabetes, because the pancreas is a gland. So that's part of our view. Then we see the adrenal glands. The adrenal glands sit on top of the kidney's not a gland, it's an organ, but one on each side. And these adrenal glands make hormone as well. And then lastly, what we call the gonads. So in men, the testes, and in women, the ovaries. And those also make hormone. So all of these glands make hormones. The pituitary gland makes stimulating hormones to make the thyroid work and the testes work and the ovaries work and the adrenal work. So that's why it's called the master gland. The thyroid gland makes thyroid hormone. The pancreas, as I mentioned, makes insulin and some other hormones. The adrenal gland makes cortisol. The testes make testosterone and the ovaries make estrogen. What's very interesting to the endocrinologist is that our body is very well regulated. What I say here is a series of feedback systems. Let's say the brain is not sensing enough adrenal hormone or cortisol. The brain, the pituitary gland, will then stimulate more releasing hormone to tell the adrenals to make more cortisol. So this is called a feedback system. If there's too little of a hormone, the brain senses it and helps the body regulate and get back to its usual state. If there's too little of a hormone, the brain will sense that and help the glands make more hormone. So we call that a feedback system. And in order to test for disease, if someone is making too much hormone, we'll do a suppression test. If someone is making too much hormone, we will try to suppress them to see if it's abnormal or not. So it's called a suppression test. And if someone is making too little hormone, we try to stimulate them to see if they can make enough. And if they don't pass those tests, then we know we have a problem. So that's just a really general overview of just glands and the endocrine system in general. So now we'll delve into the thyroid. So how does the thyroid work with all of this? This is just a very kind of basic schema, but there's this hypothalamus in the brain, which is a very important part of our brain that makes certain kinds of stimulating hormones, and that's called thyroid releasing hormone. So the hypothalamus helps the thyroid, releases this hormone to stimulate the pituitary gland, which is also in the brain, so it doesn't have very far to go, to make a hormone called TSH. TSH is thyroid stimulating hormone. And that's what that hormone does. It stimulates the thyroid to make thyroid hormone. So this is a stepwise process, right? So then the thyroid here, this butterfly, is then going to make thyroid hormone called T4. 98% of what the thyroid makes is T4, and just a teeny bit is T3. So these are the two thyroid hormones. These are the main ones that we use for blood tests, TSH, T4, T3, but we'll talk about that later. So then these hormones, T4 and T3, they get released from the thyroid in the neck, and they go to the tissue in the body that needs it. What needs thyroid hormone? So many areas of our body, which is what's really cool about endocrinology, is that it really affects the majority of our systems in our body. So everywhere from the brain needs thyroid hormone, the bones, the liver, your metabolism, your temperature regulation, your heart, so many things need thyroid hormone. That's why it's so important. Then once thyroid hormone, particularly the T4, which is why this is a bigger arrow than the T3, once it gets to the tissue, the T4 then gets converted by an enzyme. An enzyme is something that breaks things down, that gets converted by an enzyme from the T4 hormone to a T3 hormone. Why is that important? Because T3 is the active form of thyroid hormone. So if we don't have T3 in our body, if we're not converting to the T3, you're not getting the thyroid hormone that you need to exist.
So the T4 on its own, it needs to go through that process of converting to T3 in order to be useful to the other parts of the body, correct?
That's right. It gets transferred from the thyroid, it gets released from the thyroid, goes through the blood, goes into the tissue, where I just mentioned these three types of enzymes. The enzymes take the iodine, which we'll talk about how iodine is important, takes a little iodine molecule off of the T4, and that's how it gets its name of T3, because it has three iodine molecules.
3 instead of 4.
From 4, yeah. And so these, they're called deiodinases. Anything with ACE at the end of it is an enzyme. And these deiodinases, which take off an iodine molecule, they work in different parts of the body. So you'll find the D1 in these organs. You'll find the D2 in these organs or tissue, and then the D3 here. Now, D2 is really the most important one. You can see it's in the brain, and it actually is the most efficient at converting the T4 to the T3 where it's needed. The type 1 doesn't do that as well, and the type 3 actually converts the T4 into a non-active hormone.
What the difference is between the TRH and TSH? Is it just the source, or is there any sort of difference that we should be aware of?
They're both hormones. TRH is TSH releasing hormones. So it comes from the hypothalamus in the brain, travels down some nerve endings. It travels down to the pituitary, and it stimulates TSH production.
And it's a sort of a chain reaction.
So if you don't have your TRH working, let's say someone, God forbid, gets in an accident and they hurt their hypothalamus, and that we cancel out the hypothalamus, then thyroid hormone won't be produced. So this is a very busy slide, but what it's showing is that all the different proteins that are needed for thyroid hormone synthesis. But here is a very important transport mechanism where iodine goes into the cell. So this is the thyroid cell, and it goes into the cell and it gets changed and things attach. The I is always the iodine, the T is the thyroid, and eventually it becomes the T4, where it's a molecule of thyroid with 4 iodines. And then there's a protein called thyroglobulin, which is in all the thyroid cells, and that's very important for synthesis or the creation of thyroid hormone. And then all of these proteins, the cell transports them back out into the thyroid, which is held in the thyroid and ready for release when the TSH says it should get released. So this T4 is the majority that's produced, the T3 a little bit, as I mentioned, and thyroglobulin is a protein that we also can measure in the blood, but it's made in the cell. It's a very kind of high level view of a very tiny little cellular structure. So now I want to talk about what happens when something goes wrong with the thyroid. And the two most common types of thyroid malfunction are either producing too much or producing too little. First, we'll talk about when the thyroid produces too much thyroid hormone. This is called hyperthyroidism, so overactive. When I think of hyper, I think of overactive. Let's go through this schema because remember, this is our normal. We have the hypothalamus and pituitary. The hypothalamus making TRH stimulates the pituitary, which makes the TSH, that then stimulates the thyroid, that makes the T4 and the T3, and it's this feedback system. When you have primary hyperthyroidism, it means that something is going on with the thyroid gland that is making excess thyroid hormone. And what happens is all that thyroid hormone signals back to the brain in both of these sites to stop making the releasing hormone and the TSH because we don't need it anymore. So what could be going on with the gland that is making too much hormone? There's an autoimmune disease called Graves' disease, which I mentioned over here. And there's very classic signs of Graves' disease, but the way we really test for it is by looking at antibodies in the blood. Listed here, some of these antibodies. Another reason the thyroid can be making too much hormone on its own is something called a toxic nodular goiter or toxic nodule. So that means that there's a nodule in the gland that has just decided it's going to make its own thyroid hormone in excess of what the body needs. So that's what we call a toxic nodule or nodular goiter, because there could be more than one. So that's why it might be a toxic nodules or nodular goiter rather than just one toxic nodule. Then there's something called thyroiditis. Thyroiditis is really interesting. Thyroiditis is a release of all the hormone that is in the gland. And what might trigger that? Something like a very significant illness, a viral infection is usually something that comes before thyroiditis. And luckily, thyroiditis is a short-term thing and we recover from it because what it does, it releases the hormone from the gland and you feel really crummy. You have all the symptoms of hyperthyroidism, but then over the course of a couple months, the gland recovers and you do have to see the doctor and we help you, but it does thankfully recover. And then there's something called a TSH-oma, which is a pituitary tumor. So imagine a pituitary tumor or a little growth that makes too much TSH, which then just constantly stimulates the thyroid to make hormones. So that's a little bit different and it's extremely rare. In fact, I've only seen one in about 20 years or two. So it's very rare. So these are there's obviously other more esoteric or rare forms of or causes of hyperthyroidism. I just wanted to list the primary ones that you may have heard of or want to know about. So what do we usually see with hyperthyroidism, overactive? So just going again from head to toe, like I said, the thyroid affects many things in our body. So one might be in terms of mood, hyper, agitated, nervous, irritable, you can't sleep. Sometimes people have depression, but mostly what I see is a lot of moodiness, agitation. Some people can have hair changes like dry hair or broken hair or hair loss. Some people have an enlargement of their thyroid, so it gets bigger. Usually it doesn't cause pain, but sometimes with that thyroiditis, there can be pain in the neck or pain in the thyroid. People have weight loss, unexplained weight loss. They can feel very hungry and eating more, but losing weight. They can have increased motility of the gut. So they can have loose bowel movements, more bowel movements, because everything is revved up. Think about it like that. The heart rate is increased. They're tachycardic, what we call tachycardia, too fast of a heart rate. Blood pressure might be high. eye. Their fingernails might change. The skin is hot and moist and more smooth than usual. And then they can have weakness, particularly of the large muscles. So what I always ask patients is, are you having a harder time getting up the stairs without feeling short of breath? So those quad muscles, are you having a hard time brushing your hair now? If someone has a lot of hair and they might feel weak because these larger muscles in the arms and legs are weaker. And then for women, their menstrual cycle can be off or changed. I just want to talk about how do we diagnose hyperthyroidism. Again, I mentioned we do blood work. So we do the TSH level, the T3 level, the T4 level, and those antibodies. And then we can also do something called an iodine scan. Remember, iodine is used by the thyroid and it's very unique in the body. Not other places in the body use the iodine other than the thyroid. So we are able to tap into that uniqueness and say, okay, I'm going to give you a little bit of iodine, and then I'm going to take a picture of your gland. And look at this. You can see the butterfly, but here you see this one hot spot. That is a hot nodule. Okay, so this is a scan showing us this hot nodule in the anterior and the posterior view. So that's diagnostic for the hot nodule. This is diagnostic of the Graves' disease, the autoimmune one that affects the whole gland, because the whole thing is hot. It's all taking up a lot of iodine. And then I just wanted to say that sometimes we'll do a thyroid ultrasound to look at the thyroid and see if there's any nodules and look at what those nodules look like. Or when we feel the thyroid, if we feel a bump or a lump, we may go ahead and do an ultrasound. And this is what a thyroid gland looks like on ultrasound, which I love. So anyway, I just
That's
wanted
pretty
to show it.
cool. That gives you a good sense of where it is.
Yeah, here's your trachea, and then it just lies over the trachea. And here's your carotid artery on both sides. So this is the right side of the thyroid, the left side, and then the isthmus, that connection part.
Very cool.
So that's how we would diagnose it. And then treatment really depends on the etiology, meaning what the cause is. So if someone has the Graves' disease, which affects the whole gland, we usually can use medications that block the thyroid from producing too much hormone. Or we can use radio-labeled iodine, which is a pill or capsule that's swallowed. And that iodine that's labeled with radiation will go to the gland and kill those cells. Or you could do surgery. There are scenarios where surgery is indicated, particularly if someone is unable to tolerate the medications, or if someone is young and wants to get pregnant, and these medications may have some congenital implications for pregnancy. And radioactive iodine cannot be used when someone wants to get pregnant for about 6 to 12 months. So surgery is definitely an option there. For Graves' disease, that would mean taking the whole thyroid. For toxic nodule or nodular goiter, we can use radioactive iodine because that nodule or nodules will take up the iodine and get killed and leave the rest of the gland alone, hopefully. Or you could do surgery to remove it. And sometimes we'll use the medications just to bridge to one of the more definitive therapies like radioiodine or surgery. And then, as I mentioned, thyroiditis is this interesting thing, which again is sometimes triggered by a virus. I actually saw more of it during the COVID time, and I always see a little bit more of it during RSV season, where we just get that release of hormone and we need to manage people's symptoms. They really don't feel good. So we can use something called a beta blocker, which can slow that heart rate because they're feeling so out of breath and fast heart palpitations. So we can slow that down. Also, the heat intolerance, feeling too hot and sweaty, gets better with the beta blocker. If they have pain in the neck, we can use steroids or non-steroidal anti-inflammatories. Aleve, for example, can be helpful. And then again, thyroid levels usually resolve without treatment, but it does take a few months.
This was something I thought that one of the associated symptoms with Graves' disease is having like enlarged eyes. Is that a thing?
Graves' disease is associated with thyroid eye disease.
Yeah.
It's also associated with some skin changes, but that's more rare. So thyroid eye disease is a diagnostic feature of a Graves' disease. If we see a patient and they have the classic stare where more of the white on top of the eye, we do an exam called a lid lag test. If they have injection of the eyes, meaning that they're very red, some people will have tearing, some people will have a gritty or sandy feeling in in the eyes because they're dry. We always, with patients who have Graves' disease, will send them to the ophthalmologist to get a baseline eye exam, because even if they don't have the eye disease at the time of diagnosis, it is still possible to get the eye disease later. So we like to have a baseline.
So you can monitor if it
Yeah.
progresses.
Yes. Yeah. If they then do get it and then decide how to treat. But I will say that treating the thyroid can help minimize symptoms of the eye disease and also can help prevent the onset of the eye disease.
Gotcha.
The other thing that helps prevent it is not smoking. So smoking does increase the risk for thyroid eye disease.
As with many things, that it is helpful not to smoke. Yes.
So this is the story about hypothyroid. So hypo is underactive, hyper overactive, hypo underactive. So here what we see is, this is again the normal situation, but here with hypothyroidism, I'm going to X out the gland. Something is wrong with the gland. It is not making the T4. That sends a signal back to the brain, both of these, to pump out more of TRH and TSH. We can't measure TRH in our blood, but we can measure TSH in the blood. So the typical pattern of a hypothyroid lab is to see the low T4 with the high TSH. People get confused all the time. They see their TSH very low and they're like, oh, I'm low. I have hypothyroidism. No, that's the opposite. That's the hyper state. Remember, you have too much, it shuts down the TSH. Here we have too little T4 and we see a high TSH. So that's what you're looking for on your blood test. The most common cause of hypothyroidism is something called Hashimoto's thyroiditis, which is a chronic inflammation of the gland. Why do we get it? Sometimes it can be acquired through family. It's very common to see in families. We don't always know why someone gets it. It can be from environmental factors, but 8% of all women have these antibodies, which is a large number. Even though it sounds small, it actually is a large number. And it's probably a little bit undercounting because many women don't even know that they have it because we don't test everyone. And about 3% of that 8% get hypothyroidism. So you can have the antibodies or Hashimoto's without being hypothyroid. And that's the most common scenario. But it does increase the risk of one getting hypothyroidism or underactive thyroid. If you know you have the antibodies, you do have to monitor for thyroid dysfunction. How else can people become hypothyroid? As I mentioned, surgery. You could take out the thyroid for various reasons. If it's a big goiter and you can't swallow or breathe, you need to have it out. If you have thyroid cancer, we sometimes have to remove the whole gland. If there's surgery to the pituitary, for example, and you can't stimulate the thyroid to make hormone. So there's many reasons. Some medications change the levels of thyroid hormone and radiation. Some people who've had radiation for one reason or another, maybe they had, God forbid, a cancer of the neck or a cancer in the brain that they had to have radiated around the pituitary or the thyroid. Over time, it can not function, either one. And then some people have iodine deficiency, which usually does not occur in our country because we have a lot of foods that are fortified with iodine. But there are countries where many people are iodine deficient and they end up having an enlarged thyroid or a thyroid goiter. Iodine is very important, particularly during pregnancy. So the recommendations for pregnancy and iodine is that you need to take more. So that's why our prenatal vitamins have iodine in them. And some people who don't use iodized salt or totally avoid salt, for example, you may need a little bit of iodine by another means. What about hypothyroidism signs and symptoms? Things we ask about with our patients, things we look for on exam. This is a person who may have what they like to refer to as brain fog. They just don't feel clear. They may have poor memory or concentration. In general, they might just feel fatigue. They're on the colder side. They might have weight gain, not a great appetite. There can be swelling in all the parts of the body. So you could have have swelling in your legs. You can have swelling around your eyes. You can have swelling in the ear, which can lead to some poor hearing. You can have swelling of the tongue. Those are very severe scenarios when you start having swelling of the tongue. I don't usually see that in the clinic, but we can see a slowed heart rate. When it's very severe, you can have fluid around the heart. On exam, we always tap on people's reflexes to see if they're delayed, because that can be a sign for me to tell them that they're hypothyroid. Carpal tunnel is associated with hypothyroidism, some shortness of breath, fluid around the lung. The skin changes. You can have some dryness and dimpling of the skin, particularly in the lower extremities. And then constipation is a big one. And then people can have irregular menses again. So some of these things overlap with the hyperthyroidism, and that's why you have to do a good clinical exam and a good history. Also, people can have an enlarged thyroid gland. So in general, most common symptoms are fatigue, feeling cold. Sometimes the menses are abnormal, constipation. Those are very non-specific things, and sometimes hair loss. And like iron deficiency could lead to that. So you have to have complete workup when you have those symptoms, but like slowed heart rate, for sure, you got to get into the doctor. So what do we look for? I mentioned that on the blood tests, the TSH will be high for hypothyroidism and the T4 will be low. We can look for these antibodies for the Hashimoto, like the TPO antibodies. Sometimes if those are negative, but a doctor's really suspicious that one does have the antibodies, we'll test this other one, the thyroglobulin antibody. And then sometimes, again, if we feel something abnormal on our clinical exam, we'll do a thyroid ultrasound. Sometimes you can have a high TSH with a normal T4. And that's probably the more common scenario that we see in our patients, because that's called subclinical hypothyroidism, and they're not quite severely overt because they already have some symptoms at that point.
Borderline underactive thyroid, is that just where you monitor it to see if there's further problems?
Yeah, so that's like the subclinical hypothyroidism that I'm mentioning.
Gotcha.
If the T4 is still normal and the TSH is only mildly elevated, some people do not need treatment. They just need to be followed. And whether or not someone needs or wants treatment can be discussed with the doctor, because sometimes we will try a little thyroid hormone if everything else is normal, they're not anemic, and see if symptoms get better. But they don't have to be treated when it's subclinical. You do have to be treated when it's overt hypothyroidism, and we treat with T4 and T4 hormone predominantly, and it's called levothyroxine, and the brand names are here. Just some of the brand names, for example. Sometimes we'll add in a little bit of T3, which is that active form of the hormone, and it's liothyronine is the generic name, and then the brand is called Cytomel. And typically, again, we only would add in the T3 if there's a rationale to do so, that it's not a first-line agent usually, because the T3 is the active form and it's very potent. It's 4 times as potent as the T4. So we start to worry about people getting palpitations or heart arrhythmias if we give too much of that. And then there's something called desiccated thyroid hormone, which is an extract that's from pig or cow thyroid. And because they're taking it from the whole thyroid, you do get some T3 and T4 in that. So the ratio of the T3, T4 in the animal is not the same as in human. They have more T3 in their gland. Some patients prefer this. It does make our ability to monitor labs a little bit harder. I would say that for people who have underlying heart disease or heart palpitations or feel agitated at baseline, this would not be a good option. And then some people may ask, how do you know how much to give of each? There's a conversion chart. These are the types of desiccated thyroid, these 3, and then how to convert to the levothyroxine, the T4 type. But it's not a 1-to-1, so it is a guessing game, which is a little tricky. So it always takes a little bit of time to get the right dose for each person.
And that, I'm sure, is why the monitoring part of it is so important.
Yeah.
Just making sure that it's working. Right.
Exactly. We usually monitor every 3 months because
Hmm.
the T4 is a long-acting hormone and it takes a while for the TSH to respond. So when we
Gotcha.
monitor every 3 months, we're doing the TSH and the T4 test.
How much of this is hereditary? If your mom or your dad or relatives had hypo or hyperthyroidism, how much does that affect your chances of having those issues? Or is it different with different forms?
Yes, when you think the thyroid autoimmunity is the most common autoimmunity. So when you think about autoimmune diseases like celiac, for example, or ulcerative colitis or
Hmm.
Crohn's, all these sort of broad things, within those, thyroid is the most common. If you have a family of a lot of autoimmunity, you probably have some thyroid in there. And
Hmm.
having a family member, an immediate family member with an autoimmune thyroid condition does increase one's chances of getting an autoimmune condition or like rheumatoid arthritis or something, all of those.
Yeah.
It does increase your chances. It is not 100%. I can't give you a percentage because, again, yes, every person is different. There is some sort of hint that major life stressors, if one has the antibodies in their system, may trigger them to act. God forbid, like a death in the family
Sure.
or a very severe illness in oneself. But the question is good because it does speak to the fact that these things do occur in families.
Goiter's family history. Is that something you see as well?
Yeah, I actually do see that quite a bit. And I always wonder, is it a lack of enough iodine growing up in wherever they were growing up? I
Hmm.
wonder about that or some other
Gotcha.
exposure because when it's in families and it's just goiter versus the autoimmune, I wonder, okay, what's the underlying kind of common cause there?
That's
And
interesting.
it probably is something in youth, some exposure in youth.
If you were to say to anyone just thinking about your thyroid health as ongoing things to think about, what are some things that you would suggest that people do to just maximize their chances of remaining with a healthy thyroid?
A healthy thyroid. There's not too much that you can definitively do. My thing about being healthy is eating well and exercising. You do need enough iodine in your diet, so that is one thing. Some people will take selenium for thyroid health, but you really don't have to if you have a well-balanced diet. It is used for that thyroid eye disease, but if you don't have a well-balanced diet, then you could take a little bit of selenium, not too much. That is just a mineral that supports the process of making thyroid hormone as much as you can avoid environmental endocrine disruptors. But we're all exposed to these things,
Yeah.
unfortunately. The plastics and the radiation that's just in the ambient air. In some ways, it's unavoidable.
I've seen a lot of things recently about cortisol. I think it's like the thing that people are talking about right now. And I think there are a lot of people pushing these things that are releasing toxins and doing things with cortisol and stuff. Do you have insight about that? I do think some of these are like buzzwords for supplements and things like that.
Yeah.
Yeah,
I think that decreasing inflammation in the body is important for long-term health.
sure.
And how do we do that? That's $1 million question. I think that being able to manage stress, which can be with a multitude of ways, whether it's good sleep or, like we said, eating well, doing the exercise, meditating, taking a break, taking care of yourself. I think the cortisol that's produced by the adrenal gland, like I said, that is a very tightly controlled system. So I don't buy into that the adrenal, it can work hard when one's stressed, but it's
Hmm.
not going to fade out because then you won't have a blood pressure and we can't survive. But trying to manage the stressors can help manage the inflammation. And then some patients ask me about gluten-free diets to manage inflammation, particularly in the setting of Hashimoto's, because that's chronic inflammation of the gland. There haven't been placebo-controlled trials showing that gluten-free diet is going to prevent the onset of hypothyroidism in someone who has Hashimoto's. But what I will say is that some of my patients try it and they feel better. Some try it and they don't. And so they stop. It was
Yeah.
worth the effort to them. Yeah.
Interesting. Because of hormone related things with like menopause, are there things that you expect to see more often with other hormones in the body when women are menopausal or people who have menopause? Are those not
Oh,
so related?
so your question is when the estrogen starts going down in menopause, does that
Mhm.
affect the
Affects the
other
others.
systems? It can, because we do see more hypothyroid women are over 50. So yes, it can be associated with that. There's not a one-to-one direct link with decreasing estrogen and all what's going to happen with the other hormones.
Got it. If you have seen an increase in either hyper or hypothyroidism over the past 20 years, and if so, do you have any sort of thoughts about why?
That's a great question. So I would say no to hypothyroidism. It's common, and my practice is primarily thyroid, that I've been seeing a lot of it for a
Okay.
long time.
Yeah, yeah.
Hyperthyroidism, I would say I do see a bit more lately over the last 5 to 8 years. And that could be because of different drugs that have come out that can lead to or precipitate hyperthyroidism. It also could be from these viral kind of
Yeah,
thyroiditis and
yeah.
things like that. Yeah.
Is it one of those things again where it's a good idea to get all your vaccinations to try and avoid such complications? Or do you see people even when they're vaccinated can
Yeah.
still get it?
Yeah. I can't speak to that because it
Okay,
comes both ways. Yeah.
gotcha. Okay,
Um,
but still get
but I would
vaccinated
say that
nonetheless. Yeah.
a part of a annual blood panel, I think people 50 and older, is actually thyroid levels.
Okay,
So
yeah.
that TSH probably is in everyone's annual blood test, just as a screen.
Great.